Moving on to our next speaker. So Dr. Nils Petersen will be speaking with us this afternoon. We'd like to thank him for making the trip to come give us a talk. So Dr. Petersen is a vascular neurologist and neurotensivist specializing in cerebral hemodynamics and vascular physiology. He is an associate professor at Yale University School of Medicine with extensive research in neuromonitoring, transcranial Doppler ultrasound, and near-infrared spectroscopy. Dr. Petersen earned his medical degree and PhD in neuroscience from Christian Albrechts University in Germany and completed his neurology residency at Mount Sinai Hospital, followed by a fellowship in vascular neurology as well as neurocritical care at Columbia University and Mass General Hospital, respectively. At Yale, Dr. Petersen is the medical director of the Neurosciences ICU and directs the Cerebral Blood Flow Laboratory and ICU neuromonitoring program. His research focuses on brain blood flow regulation and hemodynamic changes post-stroke to improve outcomes through personalized treatments. Dr. Petersen will be presenting on the role of non-invasive cerebral monitoring. So please welcome Dr. Petersen.
Well, thank you for the kind introduction, and in general, just thanks for having me. This has been a wonderful conference. All right, so the title of my talk is whether non-invasive monitoring can replace invasive monitoring. And my answer is, I think it depends. What are we trying to replace? If the goal is to measure ICP and guide ICP lowering therapy, then I would say non-invasive monitoring does not replace an ICP monitor, at least not yet. But ICP monitoring has increasingly been used for more than just measuring ICP. It has become a tool for understanding pressure reactivity and cerebral autoregulation. In 1997, the Brain Physics Group at Cambridge University introduced the Pressure Reactivity Index, or PRX. PRX quantifies how intracranial pressure responds to changes in arterial blood pressure. If it's calculated as a rolling correlation coefficient between slow oscillations in mean arterial pressure and ICP. And if we have intact autoregulation, then those increases in blood pressure are met with an arterial vasoconstriction, which then decreases intracranial volume and can stabilize or reduce intracranial pressure. And that correlates with a near zero or negative correlation coefficient. However, if autoregulation is impaired, then those changes or increases in blood pressure are met with a pressure-passive vasculature, and we see increases in ICP, which are corresponding to increases in the correlation index. And building on that work, Steiner and colleagues introduced that concept of optimal CPP, or CPP-opt. And what they did is they calculated autoregulatory function using PRX, and they plotted it across a range of cerebral perfusion pressures. And I'll go back, and they thereby identified like a blood pressure range or a CPP range where the ICP is most independent of cerebral perfusion pressure. And to me, that is one of the most interesting concepts and aspects of ICP monitoring. It's not just telling us the actual ICP number, but it's telling us how the brain responds using the ICP as a response of the brain to changes in cerebral perfusion, and thereby telling us what is the ideal blood pressure range for that injured brain. And that's also the conceptual bridge to stroke patients. So most of our post-thrombectomy patients do not have, and quite frankly, do not need an ICP monitor, but they still may have impaired autoregulation and pressure-dependent tissue at risk for secondary brain injury. So the question is whether we can translate that CPP-opt PRX framework to stroke using non-invasive monitoring. And blood pressure, as we all know, is commonly elevated after ischemic stroke, and it's a main driver of cerebral blood flow, but also, potentially a driver of secondary brain injury. And we know that admission blood pressure has this U-shaped or J-shaped relationship with outcome. And that patients who are at the extremes of blood pressure, so either very low or very high, are associated with worse outcome. But it's not as simple as just like bringing that or lowering that blood pressure to that range where favorable outcome meets at peak. And we have now several randomized clinical trials that have shown us that intensive blood pressure lowering after successful thrombectomy actually, either don't improve outcome or can potentially cause harm. And that's the challenge here. These failed trials doesn't necessarily mean that fixed blood pressure targets are the way to go, and that blood pressure doesn't matter. It may mean that the same target is wrong for many individual patients. As we all know, stroke is a highly heterogeneous disease, and the same blood pressure may be protective in one patient, irrelevant in another, and potentially harmful in a third, depending on their baseline history of chronic hypertension, collateral status, autoregulatory capacity, their reperfusion quality, or extent of reperfusion injury. And you can see that here on the right-hand side. These are perfusion images obtained right at reperfusion. And you can see that not even are patients different from one another. The ischemic territory itself is very heterogeneous. And within the territory, we have areas of persistent hypoperfusion. And sometimes they are apparent on regular angiography, and we see suboptimally reperfused areas, but sometimes they're not apparent. And that's why we need physiology, not just like one blood pressure number. So the key question is not simply what is the right BP. The question is the BP appropriate for this patient's injured brain? And as we all know, in the healthy brain, cerebral autoregulation maintains relatively stable blood flow over a range of perfusion pressures. However, in the setting of acute ischemic stroke, it's likely a constellation of pathophysiologic factors that reshape the autoregulatory curve. The curve can either shift laterally, the plateau can overall shorten, or autoregulation becomes less effective. Nonetheless, that range is still the ideal environment or the ideal range for the injured brain, because when we go outside, blood pressure starts to passively follow, blood flow starts to passively follow changes in pressure. And if blood pressure falls below the lower limit of autoregulation, that can lead to further ischemia and infarct progression. And then on the other hand, if we have blood pressure above the upper limit, that can potentially lead to hemorrhagic transformation or development of cerebral edema. So how can we define an individual patient's autoregulatory range non-invasively in real time at the bedside? As I mentioned, PRX uses ICP as the brain's response signal to arterial pressure. In stroke, we can ask the same physiologic question using NIRS-derived cerebral oxygenation as a surrogate for cerebral blood flow. The signal is different, but the logic remains the same. And as you may know, near-infrared spectroscopy works by sending near-infrared light through the skull and the skin, and it gets then absorbed by oxygenated and deoxygenated hemoglobin. And then the receiving light can be used to continuously estimate cerebral oxygenation. So the next step then is to convert that NIRS and blood pressure signal into patient-specific autoregulatory curves. The initial steps follow the same mechanism I showed you earlier. We begin by calculating a rolling correlation coefficient between our two input signals, in this case, arterial blood pressure and brain tissue oxygenation. And then we calculate our autoregulatory index, and we plot the autoregulatory index across a range of cerebral perfusion pressures, and that gives us this error bar chart. We then use a curve fitting algorithm to create a smoothened representation of that relationship and apply a threshold for impaired autoregulation. And that then gives us the optimal blood pressure range with the lower and upper limits of autoregulation. In between, those limits, we see that the overall correlation index or autoregulatory index indicates that blood flow is relatively independent of pressure, indicated by this low correlation coefficient. And that's the plateau of the autoregulatory curve. And if we go to either side, we see that the correlation index increases and blood flow becomes more dependent on pressure. And we can then kind of use that window and use like a longer moving window to continuously compute and regenerate these curves to give us autoregulatory limits continuously throughout a patient's ICU stay. And we have tested this concept in a series of studies and found that deviations from our computed personalized autoregulatory targets were consistently associated with secondary brain injury in the form of hemorrhagic transformation, infarct progression, and cerebral edema, as well as worse functional outcomes. I just want to briefly show you how we've incorporated continuous autoregulation monitoring into our routine ICU care as part of our broader multimodal neuromonitoring program. So we use a portable data acquisition system that records time-synchronized data from the patient's bedside monitor as well as other in-room devices. And that data is then live streamed to a neuromonitoring station in our ICU where we can visualize the data, analyze the data, and compute autoregulatory targets. We also have the possibility of remoting into those workstations and helping the clinical team with interpretation and decision making. There are some limitations and challenges with autoregulation monitoring. And the main practical barrier at this point is that it requires specialized equipment, signal processing, and expertise, which limits its use currently to very specialized centers. And before I finish, I want to briefly introduce a new concept that I've been developing together with one of our faculty, Kyle Lyman, to address some of these limitations, and very much in theme with our innovations in cerebrovascular care. So Kyle has developed this platform that can generate perfusion maps from regular, routinely acquired angiography data. And by incorporating interprocedural physiology in the form of end-tidal CO2 and mean arterial pressure during the procedure, we're then able to generate these regional maps of optimal perfusion pressure for the individual patient, and we can kind of track that out throughout the acute stroke period. And in a cohort of 62 EVT-treated patients, we found that those patients that were more closely aligned with their computed optimal pressure had overall better outcomes than those who didn't. But more importantly and interestingly, we can generate also these regional maps of tissue vulnerability. And then we can measure the pressure shortfall throughout that acute post-stroke period and see how that affects tissue vulnerability and potential progression of tissue into infarction. And if this technology turns out to be successful, right, then we have a much more scalable approach to using precision medicine in acute stroke care, because we have targets right away at the time of reperfusion without the need for any monitoring or any other devices, and that could be a game changer. So to conclude, if I need to measure intracranial ICP and guide ICP lowering therapy, then the invasive monitor remains the right tool. But ICP monitoring has taught us more than ICP threshold. Through a PRX and CPP opt, we have learned that the brain's response to pressure can define a patient-specific optimal perfusion range, and we've now successfully translated that framework to EVT-treated stroke patients. Obviously, this is all, still research, and when we do need prospective validation before this can become hopefully standard of practice. Thank you very much.
We are a little behind, but one question. I know we have Dr. Petersen has provided us with a case that we'll go over, so I'm sure we'll be asking you more questions related to that. Thank you. All right, so we're going to move on to